Persistent symptoms after concussion can be frustrating for everyone involved. The patient is frustrated because they were told they should be better by now. The clinician is frustrated because the symptom picture keeps changing. And sometimes the plan becomes vague. Rest more, wait longer, avoid symptoms, and maybe try again next week. But persistent concussion symptoms are not a dead end. They are a clinical reasoning problem. When we stop thinking of these symptoms as just concussion symptoms and start asking what systems are driving this patient's symptoms now, the case becomes much more manageable. Most people recover within 1 month, but some patients continue to have symptoms for months or longer. At that point, the question is often no longer, does this person have a concussion? The better question is, what are the current system generators? That shift matters because persistent symptoms rarely come from a single source. A patient may say, I'm dizzy, but dizziness after concussion can come from the vestibular system, cervical spine, anxiety, just to name a few. The symptom matters, but the symptom is not the diagnosis. The same is true with headache. A patient may report daily headache after concussion, but that headache may behave more like a cervicogenic headache, migraine, tension type headache, or a mixed combination. If we simply label it post-concussion headache, we may miss the treatment pathway. This is why a systems-based exam is so important. A symptom checklist tells us what the patient is experiencing. It does not tell us why. For persistent symptoms, we need to move beyond symptom reporting and test the systems that may be contributing. Persistent symptoms often live in the interaction between these systems. Poor sleep can increase headache sensitivity. Headache can increase screen intolerance. Screen intolerance can reduce work or school tolerance. Reduced activity can lower exertional capacity. Reduced capacity can increase fear and anxiety around symptoms. Now, the patient is stuck in a vicious loop. Not because they are broken, not because they are permanently damaged, but because multiple systems are feeding into each other. This is the clinical reasoning opportunity. Modern concussion care has moved away from prolonged strict rest and toward relative rest early, followed by active individualized rehabilitation when symptoms persist. Rest may have a role early, but prolonged avoidance is usually not the long-term answer. So the plan cannot simply be keep resting until symptoms are gone. The plan needs controlled, symptom-informed progression. So graded physical activity, cognitive load, visual and vestibular challenge, and return to work, school, sport, and life progression. The goal is not to flare the patient constantly, but it is also not to avoid every symptom forever. For example, imagine a patient 3 months post-concussion with dizziness, headache, brain fog, and fatigue. A generic plan might be rest more, limit screens, and come back in 2 weeks. A system-based plan asks better questions. When does the dizziness happen? With head movements, busy stores, reading, exercise, etc. When does the headache show up? Is it during activities or is it constant? Is there light sensitivity or nausea? Now we are just collecting symptoms. We are mapping patterns now. And once we see patterns, we can match treatments. If the neck is a driver, treat the neck. If the vestibular system is involved, use vestibular rehab. If exertion is limited, use sub-symptom aerobic training. If sleep, mood, or fear avoidance are major contributors, address those as well. That is much more useful than treating every persistent concussion case the same way. So when you see a patient with persistent symptoms, reframe the case. Instead of asking, why do they still have concussion symptoms? Ask, what systems are contributing to their symptoms now? Then test those systems, identify the biggest drivers, match the intervention to the driver, and track meaningful functional change. Persistent concussion symptoms are not a dead end. They are a clinical reasoning problem. And when you identify the main symptom drivers, you can build a much clearer treatment plan. If you want a practical framework to help organize these presentations, download our free guide to 6 concussion subtypes in the description below. And if you're ready to build a more complete system for evaluation and treatment, explore our online courses. See you in the next video.